Welcome to you all, and we begin our course about management of the posterior segment complications of cataract surgery. So I'm going to start the course with management of one of the most, I would say, dramatic complications of cataract surgery, like the dropped nucleus and the dropped intraocular lens. As you know, phacoemulsification with intraocular lens implant has become a standard of care in cataract surgery, and the successful outcome mainly depends on implantation of the IOL in the bag, which ensures good centration of the lens and good visual outcomes. But whenever the capsular bag is damaged during the surgery and there are difficulties in placing the IOL in the bag, it may lead to certain complications. Occasionally, the rupture of capsule and vitreous loss are also associated with the loss of whole or part of the nucleus in the vitreous cavity, and it leads to further complications. The inadequate capsular support also poses a risk for intraocular lens dislocation. So the risk factors include zonular weakness, trauma, exfoliation, mature, hypermature cataract, previous vitrectomy, connective tissue disease, Marfan syndrome, posterior polar cataract, and one more point to add is the previous history of intravitreal injection. So inadvertent posterior capsular tear or damage may go unnoticed because not always the pupil is dilated when giving intravitreal injections. And these patients, once they come up on table, you realize that they have a capsular tear. Can you please play the video? We checked there. Doesn't matter. So as soon as the nucleus drops in our settings, we don't refer the patient for a second surgery, but we try to do the surgery in the same sitting itself. So this is a hard brown nucleus which is now in the vitreous cavity. I do not use a phaco-fragmentope, but I use the cut sleeve to remove the fragment from the posterior pole. And after that, a PFCL is aspirated and preferably a 3-piece intraocular lens is placed in the bag. And this is a standard of care in a way in our settings because we have a retina facility available at the same time. But it may not be the case with everyone, and in such situations it's best to not touch the particles, don't go after them, and all that you need to do is just go back and refer this patient to your retina colleague. We've also studied some the predictive factors and outcomes following dislocated cataracts, and we have noticed that patients with small preoperative pupil size, pre-existing oculopathology, displacement of a significant lens matter, which is very important. More than 50% of the nucleus material in the vitreous cavity poses certain risks of cystoid macular edema and retinal detachments in future, so as the patients who has to undergo iris claw IOL or cystoid macular edema. So as I said, the timing of this nucleus removal is very important. In our scenario, we do have the VR setup available immediately, and therefore we try to do it at the same sitting itself. So the advantages is obviously a single surgery, so the patient is having less anxiety about this. At the same time, the disadvantages are post-operative corneal edema, small pupil, and need for additional on-table anesthesia, which can be another drawback as such, you can say. This is another patient where we encountered a dislocated intraocular lens. Can you play the video again? So you can see a small intraocular lens is just behind the bag here. It's a single piece intraocular lens. So we make a scleral tunnel. the idea here is to exchange this intraocular lens with a 3-piece IOL, because you have a good sulcus support. So the idea is to free this intraocular lens from all the vitreous attachments. So the care is taken that there is no drag on the vitreous here, so that we can free the intraocular lens. As you can see now, it's freely floating in the vitreous cavity, so it is free of all adhesions. Now I put some PFCL. You can put PFCL beforehand so as to protect the macula as well. And then with the forceps, you can lift this lens out. Already the scleral tunnel is ready, so this lens is going to go out and a new 3-piece IOL will come in. So there are different ways to remove this lens. You can even cut it into 2 halves and remove in order to preserve the astigmatism, but I don't think that really matters much. If you have a good scleral tunnel, it's taken care of. So here we have a good capsular axis support. So a 3-piece intraocular lens is the choice. Coming to another scenario where we have a So here is the situation where the whole bag along with the capsular tension ring has got dislocated. We do see these type of patients nowadays with whole bag dislocation, in especially patients who have pseudo exfoliation. So here again the forceps is used to get the lens out, but what happens here interestingly is that I am not able to get my forceps free of that capsular tension ring, and it gets somehow stuck onto it, and I can't let go the lens also with the other hand, because otherwise the whole lens will drop. So I leave the forceps out and I take the IOL CTR back complex out, but I can see that one of the fragments is missing. So probably it got entangled with the forceps and got dislodged back into the posterior segment, and then we had to go back in and then remove it. So the care has to be taken that once you remove the whole bag capsular segment, you have to make sure that the retina is scanned once again to see that there are no inadvertent remnants inside the vitreous cavity that may surprise you next day post-operatively. Coming to which lens, when and where and why. So there's an algorithm which the American Academy has presented recently. So the patient who has good intact anterior capsule, you can put a 3-piece intraocular lens. If you have sufficient bag, like in patients of secondary management of children, you can place a single-piece intraocular lens in the bag. If you have sufficient iris tissue, you can plan a iris fixated IOL. Obviously, if you don't have it, you can consider pupilloplasty and then iris claw IOL, or otherwise you can obviously go for a scleral fixated IOL. At the same time, there is a study published in the Journal of Ophthalmology way back in 2015, which talks about comparison of anterior chamber IOLs and scleral fixated IOLs, and it has been shown that if you do a good anterior chamber IOL with a proper vitrectomy, it can also give a very good result. So these are different types of intraocular lenses that one can choose from. This is a patient where a dislocated lens was a 3-piece intraocular lens. So what we do here is do a good vitrectomy, and then after that we grasp the haptics with the help of forceps. The idea is to fix it internally itself. So we don't have to remove this intraocular lens. So marking is done on the sclera using Dr. Ashwin's marker. Then I am using 27 gauge trocars here. And then a PFCL is injected in the eye, the intraocular lens is floated up, and then the same lens will be then fixed from inside out. So this handshake technique will allow me to get the haptic out from one side, the care is taken that the cannula is withdrawn so that I don't entangle the haptic into the cannula. So once the haptic is out, we flange the lens, and then the same procedure is followed in the other eye, sorry, on the other haptic. So the assistant is holding on to the haptic which is already externalized, that allows us sufficient leverage to ensure that the second haptic doesn't slip out. And once both the haptics are out, all that remains is to flange it and then tuck it back into the scleral pocket. And then care has to be taken that the PFCL is removed, the periphery is scanned, and the scleral tunnel, if you have made it pre-operatively, you can probably close it if needed. So which lens is the preferred choice? We have recently conducted a survey across India, and it seems the retropupillary iris claw fixation is the preferred technique by the anterior segment surgeons, whereas the experienced retina surgeons tend to prefer the scleral fixated IOLs. At the same time, if the patient comes for aphakia management, surgeons tend to prefer a scleral fixated IOL over iris claw.